now?
I am being treated, yeah, it's not working really well.
Okay. When did you start that treatment?
2 years ago.
Any surgery or lasers to your eyes?
No.
Okay. Well, let's take a look at you. Oh, I'm gonna pass that to you.
Thanks.
Put your glasses on, please. Put your feet there so I don't run them over. There, fall against the bar. Come on. Okay. Trace the one plus. Top block flame hemorrhages, superior nasal macula. Sit back. Oops, sorry, I'm getting this straight. Now, Reggie, head back. With your eyes only look up. To the right. Right down. To the left. Look up. To the left. Look down. To the right. Okay. So the reason why your vision's off is you have some swelling in your macula, which is the central part of your retina that allows you to see. And the reason why you have that swelling there, it looks like you've had something called a vein occlusion. Basically, blood is flowing into your eye, but it's not flowing out very well. You need to do a test called a fluorescein angiogram, where I put some dye in your veins and look at the blood circulation in your eyes. We'll get that done, we'll look at it, and then we'll talk about what treatments you need.
Okay.
Okay?
Sounds good.
Hang on right here, Missy will get you ready. I'll see you as soon as it's done.
All right.
Okay. Left eye.
So those pictures.
So basically the lines here that are white are your blood vessels. You can see that this one kind of trailing in here is still dark. It's filling in slower than the other, and that's your one vein that's kind of being affected by this. The little black things here are actually some blood that's in the way. That's your left eye. Once the dye gets in, you start seeing white throughout the tissue, which is some of the dye leaking out of the tissue, and it's associated with these black spots here in this elevation, which is fluid in the tissue. And that fluid keeps you from seeing. This is a picture of the eyes. Blink. This is your left eye, and right there are the hemorrhages that are in the eye. Some particular staining in the right eye and the left eye temporally. So pretty classic for retinal vein occlusion. The good news is it's not too ischemic or starved for oxygen. So the way the back of the eye works, the arteries and the veins cross one another. Even though this is a vein occlusion, it is caused by hardening of the arteries, cardiovascular disease. The muscular artery, when it gets a block in cholesterol plaques and deposits, it gets really stiff, and it presses on the floppy non-muscular vein and doesn't let the blood circulate very well. When the blood doesn't circulate well, you kind of get a pool of stagnation. You're not getting good oxygen and carbon dioxide swaps. You're not getting good nutrition. You start getting some inflammation. You start getting some leakage and swelling in the tissue, and the vision goes down. So we need to do two things. Number one is we need to make sure your blood pressure, your cholesterol, and your overall health is where it's supposed to be. And it sounds like you're struggling a bit with blood pressure. So definitely diet, doctor, exercise, all the things you hear about. You want to get on top of this, because this is not the only place that it's happening. It's one place we can actually look in and see it, but you probably have cardiovascular disease going other places as well. So you definitely want to jump on top of that. And then we want to treat this fluid because one is preventing you from seeing, and if it persists for a long time, the decrease in vision can become permanent. And we treat this by injecting some medicine in the eye on a monthly basis. Those injections do a wonderful job with vein occlusions. The vast majority of patients, 90% or more, the fluid goes away and they see better. The issue with the vein occlusion is it can be a chronic problem. The body can reroute the blood circulation to the back of the eye, but it seems like that could be a 3 to 5 year proposition. So we may be looking at injections over a long period of time. We do these in clusters because what we don't want to do is have the retina go flat, and swell, because that mechanism of swelling stretches some cells that are in there, and over time, if it keeps doing it over and over again, it can cause some damage. So you get 1 shot a month to start for 7 months. Then we stop, because again, in most cases, the fluid's gone away. We don't know if it's the medicine working or if your body's rerouted it, so we stop and see if it swells again. If it does swell again, which unfortunately does in most people, you get 1 shot a month for 6 months, and we repeat the cycle. Sooner or later, we stop, the swelling doesn't come back, and that's when we just stop and just keep watching. Okay? Been doing this for the shots 12 years, I think we're up to 13 years. I've never had this discussion where somebody doesn't get a little nervous thinking about a needle in an eye. We do, and all I can tell you is what all these patients have told me over the years. They're nervous for the first one, but once they get done, they say no big deal. We have to put some iodine in the eye to kind of clean it off. That'll leave it feeling pretty scratchy. It can make it a little blurry. For some people, it's a few minutes. For some people, it's the better part of the day. Everybody reacts to it a little differently. Overall, a safe procedure, about 1 in 3,000 chance of bleeding, infection, detached retina, or damage to the lens in your eye. Okay. Biggest, probably the hardest thing about it is all the new insurance and everything. So we have a whole team that does nothing but that. We'll try to get you approved for tomorrow. I do my procedures on Wednesdays. We may not be able to get it. It's getting, even 24-hour approvals are starting to get challenging. So it may be a week from tomorrow that we start. Okay.
Okay, I'm just trying to think what's tomorrow.
Wednesday.
Yeah, I know what day, I just wanna know what week.
If you can't make it, doing it next week will be okay as well. You're a bit myopic, so the glasses you wear, basically your eyes grew long as you were a young man, the retina doesn't grow. That puts you at a slightly increased risk for a retinal detachment compared to the general population. So any new flashes of light, floaters that you've never seen before, shadows or curtains coming towards the center of your vision, you need to call us, because that could be a retinal tear or a retinal hole. Don't see anything like that, but you are at a greater risk than the general population.
He did have some floaters last year.
Okay. I don't see anything now, so if there's any new ones, you let us know.
Actually, I think, I do have a field trip. Tomorrow, so.
Okay. Like I said, they'll work out your schedule up front.
Okay.
Any other questions for me?
Will I be dilated during the injection?
Just that one eye. Most people, when they get one eye done, drive themselves, but you may want to have a driver for the first one just to know what it's like. Okay?
Nice, good.
Nice to meet y'all. Have a great day. You're welcome. Stay warm and dry out there. We'll see you next trip.
Hey.
Got a few papers that I'll send.